Today's lecture covers the biomechanics of gait. The content of this lecture is covered in Chapter 15 of the Newman textbook. Our first goal today is to review the basics of describing gait. Simple concepts over the next few slides provide important fundamentals for making sure we all have a shared language for talking about gait patterns such as walking, which we'll be focusing on today. Walking is a repetitive activity comprised of multiple gait cycles. A gait cycle occurs between two heel strikes of the same foot. Analysis of gait will often talk about what is going on at a certain percentage of the gait cycle. Typically, 0% is the moment at which the right heel strikes the ground, and 100% is when the cycle has completed and the right heel strikes the ground again. In order to talk about what is happening in the gait cycle, it's useful to have terms that identify specific phases within the cycle. The most basic distinction is between stance phase and swing phase. Notice that what we are doing here is describing what the right leg is doing. In the stance phase, the right foot is in contact with the ground. In the swing phase, the right foot is not on the ground. The gait cycle can be parsed further into different subphases. The commonly used terms for identifying the different subphases in the gait cycle are as follow. We have initial contact and loading response, where the right foot first makes contact with the ground surface and the right limb first begins to accept the weight of the body. We have mid-stance and terminal stance. Next we have pre-swing. In pre-swing the foot is still on the ground. Notice that we are still in stance phase though. But what we're seeing here is that the foot is starting to move to posture itself towards going into a swing. Next we have the initial, mid and terminal phases of leg swing. Another way of classifying the different phases of the gait cycle is to talk about the difference between double support phase and single support phase. In a double support phase, both feet are touching the ground at the same time. In the single support phase, only one foot is touching the ground, while the other foot is moving through the air. During the double support phase, the body is more biomechanically stable. Consequently, people who are worried about falls are likely to walk with a gait pattern where the proportion of the gait cycle that's spent in double support phase is increased. The proportion of the gait cycle spent in single versus double limb support varies significantly with gait velocity. Here we see a gait cycle represented that's completed in 1.1 seconds. This would be in the ballpark of an average gait cycle time. In this case, we see that double support accounts for about 25% of the total gait cycle. So about a quarter of the time, the person walking in this way has both of their feet on the ground at the same time. Here we see a gait cycle that's completed in 2.5 seconds. This is a pretty much very long gait cycle time that would be associated with a person walking very slowly. Here we see that the double support time has increased dramatically. Now let's move to talking about gait cycle parameters. Gait cycle parameters are simple ways of quantifying or measuring gait. For example, we can quantify gait in terms of its stride length or stride duration, and we can quantify gait alternatively in terms of its step length or step duration. Simple measures like this frequently get used in the clinic and in clinical research to provide simple overarching measures of gait, or simple summary measures of gait. Because of this, it's important to know the difference between them. A stride is a sequence of events that occurs between successive heel strikes of the same foot. A step occurs between two heel strikes of opposite feet. Gait asymmetries, such that you might observe in a patient with hemiparesis following a stroke, can be quantified by looking at the relationship between affected side and unaffected side gait parameters. To sum up the basic concepts that we've just gone through, walking is a repetitive activity comprised of multiple gait cycles. The gait cycle is a sequence of events that occurs between successive heel strikes of the same foot. A stride occurs between two heel strikes of the same foot. A step occurs between the heel strikes of opposite feet. Gait parameters can be split into spatial descriptors of gait and temporal descriptors of gait. Some of the basic spatial descriptors of gait, together with their approximate normal values, are as follows. Stride length has a norm for healthy adults of about 144 centimeters. Step length has a norm of about 72 centimeters. The norms we have here are taken from a study where 2,300 pedestrians were observed, and these values were determined from those observations. Later on in the class, we will look at studies creating estimates of gait parameters within the laboratory, and you'll see some subtle differences between the two. Step width is the lateral distance between heel centers at heel strike. The norm for healthy adults is between 8 and 10 centimeters. Foot angle is the angular measure of the amount of toe out, and is typically between 5 and 7 degrees in young healthy adults. Foot angle can be calculated as the angle between the line of progression and the long axis of the foot. The line of progression is the line between two heel centers of the same leg at successive heel strikes. So this line is telling us the direction in which the gait is progressing. The foot axis is the line passing through the heel and the second toe. Stride length, step width, and foot angle are all measures of either lengths or angles, and as such they're classified as spatial descriptors of gait. Some of the basic temporal descriptors of gait, together with their approximate normal values, are as follows. Cadence is defined as the number of steps that are taken per minute. The norm for healthy adults is between 100 and 131 steps per minute. Walking speed is the distance travelled over a given time. The norm for healthy adults is 1.37 meters per second. What does it mean to measure gait parameters? To understand this, let's have a look at one method that's been used. In this study, we have a patient walk across a room. They are asked to walk across the room at a comfortable pace. The dashed lines are laser beams that are tripped when the patient walks in front of them. When the first beam is tripped, a timer is started, and when the second beam is tripped, we stop timing. Notice that the patient starts walking a number of step lengths before the first laser beam. This way the patient can establish their walking pattern before we start our measurement. By knowing the amount of time it takes to walk between the two lasers and the distance between the two lasers, we can get a very accurate measure of gait velocity, or speed. To get an accurate measure of step or stride parameters, we need to be making our measurement relative to heel strikes. Rather than starting our timer when the laser beam is crossed, we start the timer when there is a heel strike just before the first laser beam. We then stop the timer when there's a heel strike immediately after the patient has crossed the second laser beam. We can then count the number of steps, the number of steps that we've got. In this picture here, we have 11. We can also measure the amount of time it takes to produce those 11 steps. Using these values of number of steps and the time taken to produce the steps, we can calculate step frequency as the number of steps divided by the time taken to produce those steps. Lastly, we can combine the knowledge we have gained and use our measure of velocity and our measure of step frequency to calculate step length by dividing velocity, which has units of meters per second, by frequency that has units of seconds to the -1. A simpler way of measuring step length in the clinic is to have a patient walk on paper or on pavement with wet feet. Let's look at some data that was collected using the method that we described on the previous slide. Here we see measures of step length for groups of men and women aged between 10 and 80. We see that step length is on average 60 centimeters, and that this does not seem to change reliably with age, except maybe for the youngest participants who are probably shorter. We also see that on average, women have a slightly shorter step length. This is probably also related to leg length differences associated with differences in the average heights of men and women. Next, let's look at the data for gait velocity. We again see slightly faster average walking speeds adopted by the male participants compared to the female participants, and we also see the suggestion that the youngest and oldest participants are walking more slowly. The data we just looked at was for participants walking at a self-selected speed. That is, for participants that were walking at a speed that felt comfortable to them. Now let's look at a study where participants were either asked to walk at a comfortable speed or to walk at a faster speed, to walk quickly. In this study, participants walked at 218 centimeters a second when they were asked to walk quickly, and they walked at 151 centimeters per second when they were asked to walk at a comfortable pace. When we ask subjects to walk quickly rather than at a comfortable pace, what changes in gait parameters do we actually end up seeing? When we ask someone to walk faster, the resulting increase in speed can be obtained in one of two ways. Walking speed can be increased by adopting a shorter step duration. This is the same as increasing cadence. Walking speed can alternatively be increased by adopting longer step lengths. In the first case, we're increasing speed by changing the temporal parameters of gait. In the second case, we're increasing speed by changing the spatial parameters of gait. In the blue bars, we see data for a group of men asked to walk at a comfortable speed. In the green bars, we see data for men asked to walk with a faster walking speed, or to walk quickly. In this data, we can see that the duration of the gait cycle was shorter when the participant was asked to walk more quickly. The stride time, or the time between two heel strikes of the same foot, was 1.06 seconds when participants walked at a comfortable pace, and 0.87 seconds when participants were asked to walk quickly. When you look closely at the data in the blue and green bars, you can see the point that we made earlier being illustrated. When participants walked faster, there's a relatively shorter period of double support. In the case of step length, here we see an illustration of the changes that take place. We see that the participants in this study had a much larger step length when they were asked to walk faster. The last thing I want to show you on this topic is here I've calculated how much step duration and step length changed as a function of being asked to walk faster. What we see here is that the participants changed step length duration, or their cadence, by about the same proportion as they changed their step length. So in both cases we see about a 20% change. I mention this because it provides an interesting contrast to running. In running speed initially involves an increase in stride length, but most of what's involved in running faster depends upon having a greater frequency of movement. In other words, having a faster cadence and lower stride duration. I now want to show you the results of a study that's not in the textbook. This is a study that was led by Richard Bohannon, a former faculty member in the DPT program. Richard evaluated the gait speed of male and female participants at various ages. He asked each participant to walk either at a self-selected comfortable speed or at a self-selected maximal walking speed. The evaluation was performed over a distance of 25 feet and took place in Coons Hall, which is where the DPT program used to be located. Here we see the data that was recorded, and here we see a subset of this data represented in a graph. If you look at the graph, something should jump out at you. Although there are differences in comfortable walking speed with age, the differences are not very large, and they don't seem to be reliable differences. In contrast, when we look at the data points for participants walking at their self-selected maximum velocity, we see that there are reliable and systematic changes. What this potentially means is that the measure of self-selected maximal velocity seems to be superior to the measure of self-selected comfortable velocity when it comes to evaluating the effects of age-related changes on gait. Let's look at this data in another way, by looking at the results of the statistical analysis that was performed. In this study, it was found that self-selected comfortable velocity was correlated with age, with height, and with measures of muscle action strengths such as ankle dorsiflexion strength, knee extension strength, hip flexion strength, and hip abduction strength. If you look closely at the results of the statistical analysis, you will notice that although these are all significant correlations, and by that I mean the p-values are all below 0.05, that they all have very weak relationships, with the R values or Pearson correlation coefficients all being below 0.3. What this is telling us is that only a small amount of the variance is being accounted for. When we look at self-selected maximal walking velocity, we find it to be correlated with age, height, gender, which we didn't find turning up in a statistical analysis before, it wasn't significant before, and the various measures of muscle action strengths. If you are paying attention to the R values, showing the Pearson correlation coefficients, you will have seen that every one of them is much larger. This tells us that the measure of self-selected maximal walking velocity is more predictive, it's telling us more about age-related changes in gaits. It's also telling us more about the functional effects of losing muscle strength. I want to go through a few simple notes related to walking speed. Walking speed is frequently used as a measure of functional capacity in clinical settings. Walking speed is believed to be one of the best simple measures of walking ability. Walking speed changes both the spatial and temporal parameters of gait, and therefore, if you're attempting to measure these parameters, you should take walking speed into consideration. While increasing walking speed, typically one first maxes out on step length and then continues to increase speed further by increasing cadence. Over the next 10 to 15 slides, we're going to review normal joint kinematics for walking. The kinematic patterns we will review are the average patterns of motion recorded in studies of the walking patterns of young, healthy adults. On each slide, I will show you graphs like the one shown here. This one's for pelvic tilt. On this graph, and with all of the graphs that I'll be showing you over the next few slides, the solid red line will be showing the mean kinematic trajectory, and the dashed lines will be capturing the variability that exists in the pattern that we're seeing across multiple measurements, measured across multiple gait cycles and across multiple participants. The closer the dashed lines are to the solid red line, the more reliable the average pattern is going to be. Your goal in working through this material is to learn to get a feel for what typical gait kinematics look like. The two aspects of the graphs to attend to when looking at each joint, we'll be going through each of the joints, is the approximate magnitude of excursion. In this graph, we only have an excursion of a few degrees, and to be paying attention to the pattern that we see as a function of the gait cycle. It's useful when reviewing this data to get up and walk around the room to help yourself get a feel for these patterns. So, on this slide, we're looking at the sagittal joint kinematics of the pelvis. Pelvic tilt is calculated by comparing the height of the PSIS, that is the posterior superior iliac spine, to the ASIS, the anterior superior iliac spine. The pattern we see here is that as the legs move together, the pelvis tilts slightly anteriorly, and as the legs move apart, the pelvis tilts slightly posteriorly. The most useful thing on this particular slide for you to remember is the small amount of motion. Given how large the pattern variability here is relative to the mean pattern, it's not particularly useful to remember the specific pattern itself, as this pattern is not going to be reliably observed across every patient that you're likely to look at. Let's look at the kinematics of the hip in the sagittal plane. So here, in contrast to the pelvis, we have a much more reliable pattern. The magnitude of variability is small relative to the magnitude of the movement pattern itself. So we see quite a large amount of movement. So when we're looking at the mean trajectory of the red line, we're seeing a large amount of movement, and that amount of movement is large relative to the amount of variation that we're seeing across strides and across subjects in the study. We see here that the hip is flexed approximately 30 degrees at heel contact. As the body moves forward over the fixed foot, the hip extends. A maximum hip extension of approximately 10 degrees is achieved before toe-off. The hip flexes more than it extends during walking. We also see here a period towards the end of the cycle where the hip is relatively stationary, and here the knee is extending rather than the hip. Let's quickly review the take-home points from the last slide. In summary, in the pelvis, we see insignificant amounts of anterior-posterior pelvic tilts. In the case of the hip, in the stance phase, the hip flexes 30 degrees at heel contact and then extends up to minus 10 degrees up to the point of toe-off. In the swing phase, hip flexion of up to 30 degrees is achieved until just before heel contact. Patients with hip joint range of motion restriction are rarely going to show gait deviations because only 30 degrees of flexion and 10 degrees of extension is needed in order to walk. Let's now look at the knee. For the first half of the gait cycle, the knee is relatively straight. That is, close to 0 degrees of flexion. It then flexes and then extends in the second half of the gait cycle. Even though the knee remains relatively extended during the first half of the gait cycle, there's still a reliable movement pattern we can see here, with the knee initially slightly flexing and then slightly extending. The small initial knee flexion occurs after heel strike and during the load acceptance phase of the gait cycle. The slight flexion of the knee in this phase is acting to facilitate shock absorbing. So the flexion of the knee during load acceptance is acting to absorb the shock of contact and the accepting of the load onto the limb. Let's summarize some of the things we should be noticed when we're looking at the sagittal kinematics of the knee. There's approximately 5 degrees of flexion at 0% of the gait cycle. This increases up to about 15 degrees as the knee flexes slightly, playing the role of a shock absorber and and facilitating the accepting of the weight of the body in this initial phase of the gait cycle. The knee then extends, reaching full extension around heel off at around the 40% point of the gait cycle. Next, the knee flexes to about 35 degrees around the point of toe off at approximately the 60% mark of the gait cycle. A knee flexion of 60 degrees is achieved early on in mid-swing at approximately the 75% mark of the gait cycle. Finally, the knee extends just short of full extension around mid and terminal swing. The knee motions that support effective walking involve a range that extends from full extension to 60 degrees of flexion. Next, we have the ankle. At heel strike, the ankle is slightly plantar flexed, up to around 5 degrees. The ankle plantar flexes into the ground to obtain foot flat. The ankle then dorsiflexes up to 10 degrees as the tibia moves on the planted foot. This takes us from around 8% to around 30% of the gait cycle. The ankle obtains a plantar flexion of up to 20 degrees just after toe off. Finally, the ankle dorsiflexes to a neutral position during swing to clear the toes off the ground. The ankle motion required for effective walking is 10 degrees of dorsiflexion and 20 degrees of plantar flexion. Let's now turn our attention to joint kinematics in the frontal plane. And we'll start by looking at the hip again. The hip is adducted during stance. This adduction acts to keep the base of support created by the stance foot underneath the center of mass, and therefore this makes the movement biomechanically stable. The hip is abducted during swing. This is associated with the swinging out of the swing limb around the stance limb. We just looked at the hip, now let's look at the pelvis. So here we have the frontal plane kinematics of the pelvis. The angle of the pelvis in the frontal plane is measured by comparing the heights of the PSIS and ASIS. For the pelvis, early in the stance phase of the right foot, in this right-footed gait cycle that we're looking at in all of these slides, we see the right side of the pelvis being higher than the left side. During the swing phase, which is the stance phase of the left leg, the left side of the pelvis is going to be higher. Let's quickly review the frontal plane kinematics of the hip and the pelvis that we just went through. For the hip, we see the hip adducts in early stance, it abducts from mid-stance to toe off, and finally it adducts for the majority of the swing phase. For the pelvis, early in the stance phase, the right side of the pelvis in our right-sided gait cycle is higher than the left side. During the swing phase, the right side of the pelvis is lower than the left side. Let's briefly consider the knee. In the case of the knee, due to high frontal plane stability, very little motion occurs. You can possibly expect to see about 1 degree valgus in stance and about 5 degree valgus in initial swing. Now let's move on to transverse plane joint kinematics. We'll start by looking at the foot. We can see here that the foot internally rotates during terminal stance and pre-swing. This coincides with the center of pressure running from the heel to the big toe, or hallux, leading up to terminal stance. The foot then externally rotates, following toe off, to bring the swing foot out and around the stance limb. The approximate norms for healthy adults are 5 to 7 degrees range of motion. Before we move on to the transverse plane kinematics of the hip and the knee, let's do a quick review. Here we see illustrations for femoral on pelvic motion and pelvic on femoral motion. Note that internal rotation produces the same relative motion between the femur and the pelvis for both femur on pelvis and pelvis on femur motions. What differs is only the segment that is doing the moving. With our mini review in mind, let's have a look at the transverse plane kinematics of the hip. For the majority of stance phase, that is from heel strike to toe off, we see that the hip is internally rotated. This, for our right-footed gait cycle, means that the left ASIS is brought forwards relative to the right ASIS. From toe off through to early mid-swing, we see a move into external rotation, and in late swing, we see this move being reversed, being brought back into internal rotation. We see maximum internal rotation at about 50% of the gait cycle, and maximal external rotation in mid-swing. In the stance phase, what we're seeing here is mostly pelvic on femoral motion. In the swing phase, what we're seeing is mostly femoral on pelvic motion. Now let's look at the knee. The knee is a condyloid joint connecting the femur and the tibia. Here we see that this joint allows for around 10 degrees of rotation during gait. The external rotation that we observe is related to circumduction, that is, for getting the swing limb around the stance limb. Throughout stance, the tibia initially rotates with respect to the femur. During weight bearing and associated knee extension, we see that the knee is in a stable fixed orientation. This relates to the screw-home mechanism. At toe off, we see the maximum internal rotation of around 5 degrees. In swing, we're seeing the tibia externally rotating with respect to the femur. Let's now move on to talking about the kinematics of the body's center of mass. Here we see some illustrations of the kinematics of the center of mass of the body. As we discussed last class, for our purposes, the terms center of mass and center of gravity are synonymous. So you don't need to concern yourself about the differences between them, or the fact that we're referring to center of gravity here rather than center of mass. In the left image, we see the sagittal plane kinematic profile being approximated by a person holding their hand up against a shop window as they walk past it. In the right image, we again see the pattern of vertical displacement, but we also see depicted the pattern of horizontal displacement, the left-right sway of the body that accompanies walking. Here, when we look at these center of mass kinematics in more detail, we see reliable oscillatory patterns with a range of motion of about 5 centimeters for the vertical displacements and a range of about 4 centimeters for the horizontal or side-to-side sway displacements. Now let's switch from thinking about kinematics to be thinking about muscle activations during gait. The form and function of a movement depends upon the ability to generate sufficient muscle force at the right time. The forces and torques created by muscles result from phasic activations. That is, they result from short bursts of activity created in multiple muscles, with each burst of activity lasting somewhere between 100 and 400 milliseconds. In the figure here, we see a list of the muscles that have been shown to provide a significant contribution to walking. And we also see the full wave rectified EMG patterns that have been recorded from each of these muscles. Something that we will talk about next semester is muscle redundancy. And by that I mean the ability to use different groupings of muscles to do the same task. Muscle redundancy means that two people might use slightly different muscles to produce their walking patterns. and that the same person might use different muscles when they get tired. Unlike the kinematics of gait, which produce quite reliable patterns across people and across times of testing in the same person, muscle redundancy means that we will restrict our discussions today to those muscle activations that are most reliably observed across testing sessions and across analyses of different people's movement. So let's have a look at the muscles that are known to be reasonably reliably recruited in each phase of the gait cycle. We'll start at the beginning of the gait cycle looking at heel strike. So here, what are the most reliably observed activations, and what functions do those activations play? The gluteus maximus is activated during heel strike. The function of this activation appears to primarily be related to the control of posture. Isometric activation of the gluteus maximus stabilizes the posture of the head, arms, and trunk, or hat segments, as they're sometimes called. The foot strike collision can decelerate the body. Given the inertia of the hat segments, this can cause the upper body to pitch forwards. Activation of the gluteus maximus creates a torque that counteracts the tendency of the upper body to pitch forwards. The tibialis anterior is also activated during heel strike. Assuming that we have a heel strike and not a midfoot strike, activation of the tibialis anterior acts to control body posture. Eccentric activation of the tibialis anterior here can decelerate the foot, slowing the plantarflexion and controlling the progression towards foot flat. The action of the tibialis anterior shows that the heel strike is not a violent slamming into the ground, but it's a controlled catching of the body. Next, we have the loading response. This is where the stance limb begins to accept the weight of the body. Hip, knee, and ankle extensors are implicated here. These are the muscles that create extension torques that act to oppose the gravitational forces that would otherwise lead the body to collapse under its own weight. The quadriceps femoris, including the vastus lateralis, vastus medialis, vastus intermedius, and rectus femoris, is a multi-joint muscle group that spans the hip and the knee. In addition to supporting leg extensions, this group of muscles plays a role in absorbing the impact of weight bearing. These muscles are seen to be eccentrically activated and act to suck energy out of the limb during limb loading. In mid-stance, we see the triceps suri recruited. Here, the gastroc and the soleus are performing an anti-gravity function, and they're keeping the body from collapsing into gravity. Other anti-gravity muscles are only minimally recruited, or are not seen to be reliably recruited. In terminal stance, hip, knee, and ankle extensors stabilize the posture of the body against the pull of gravity. In terminal stance, we also see the triceps suri performing the function of propelling the body forwards. Specifically, concentric activation of the gastroc and the soleus give the body a push forwards from behind. In pre-swing, leading up to toe-off, we see the action of hip extensors, knee extensors, and foot flexors, giving the body a last-second push from behind. Forces exerted in this phase are important, both for controlling the speed of locomotion and for controlling the direction of progression. At the end of this phase, we transition into a rapid acceleration of the hip and the knee, moving them into flexion. Here we're transitioning into the swing phase. In the last part of pre-swing, and here during initial and mid-swing, we see rapid flexion of the hip and the knee. We see the iliacus and psoas, as well as the quadriceps femoris, acting to bring the hip into flexion. We also see the biceps femoris acting to flex the knee. The function here is to actively progress the swing limb forwards. It is important to remember that muscles only tell one part of the story in understanding the movement of the body. External forces often play very important roles. By mid-swing, the quadriceps femoris is inactive, and the passive pendulum dynamics related to and consequent of the inertia of the limb is helping to carry the limb forwards. So think about holding a pendulum up, letting it go, and the pendulum, just by virtue of its own inertia as it passes the mid-swing point, is just going to keep carrying itself forwards. We see other things going on during initial and mid-swing. Hip and knee flexion and anti-dorsiflexion act to functionally shorten the limb. That is, to bring the segments of the limb up into the body. This functional shortening has two purposes. First, this functional shortening gets the foot up away from the ground, and away from the parts of and specifically away from the parts of the ground that could catch the swinging limb and cause a trip. Next, making the limb shorter and moving the center of masses of the thigh, the shank, and the foot closer to the point of rotation in the hip is going to reduce the moment of inertia of the leg. This will make the limb swing faster. Here, the physics of the limb is being used smartly to make gait more efficient. In the terminal phase of gait, we see the hamstrings acting to suck energy out of the forward-moving limb. The function here is to slow the motion of the forward-moving limb to facilitate a controlled foot strike. Together with the hamstrings, we see the quadriceps femoris being recruited. The quadriceps femoris is an antagonist to the hamstrings. This co-contraction of the quadriceps femoris and the hamstrings acts to stiffen and stabilize the limb, again allowing for a controlled foot strike. Lastly, we also receive recruitment of the tibialis anterior. This activation is made in anticipation of the upcoming heel strike. The action of the tibialis anterior acts to pre-stress the muscle in preparation for the eccentric contraction that follows heel strike. Let's briefly look at the center of pressure and ground reaction forces that are produced when the foot is in contact with the ground. Here we see a diagram showing the path of movement of the center of pressure during the stance phase. It starts at the heel when initial contact is from a heel strike and moves anteriorly along the foot, ending its path at the hallux at toe off. Remember, center of pressure is telling us the location at which forces are being exerted. Here we see the ground reaction forces at the moment of heel contact. Notice that the ground reaction force vectors are located at the heel. Remember, it is the location of the center of pressure that tells us where the ground reaction force vectors are originating from. We see that at foot contact, the feet create an anterior force and a downward force, or inferior force. In the bottom picture, we also see that a lateral force is created. Here we see the patterns of ground reaction force generated during gait. We see that the vertical ground reaction force rapidly increases following heel strike and during the loading phase. Note that the vertical ground reaction forces temporarily exceed 100% of body weight. This is due to the dynamic loading and the inertia of the body effectively increasing the forces that are created. We also see the vertical ground reaction force dip below 100% during mid-stance. This is showing us that to some degree the body is being thrown upwards, and the inertia of the body is pulling it upwards. Next, in the red lines, we're seeing the forces that are acting to catch the body, and then to push it forwards. Lastly, we see that the mediolateral ground reaction forces are mostly medially directed in opposition to the foot lateral forces. In the final part of today's class, let's look at gait dysfunctions. Common causes of pathologic gait include pain, central nervous system disorders, and musculoskeletal system disorders. The first common gait dysfunction we're going to look at is antalgic or against pain gait. This might be seen in patients with a painful knee, ankle, or hip. With antalgic gait, it is reasonable to expect to see a decrease in the percentage of time with which the affected limb is loaded. Thus, we might see a decreased swing time on the unaffected side in order to unload the affected limb more quickly, and consequently a decreased stance time on the painful limb. With pain on one side, we can expect these adaptations to pain to create step length and stance time asymmetries. Next, let's look at Parkinsonian gait. Individuals affected by Parkinson's disease can develop a shuffling gait. This gait is marked by shortened steps and higher cadence. Characteristics of this gait include a shuffling of the feet and an increase in the degree of flexion in the trunk, at the hips, and at the knee. Additional characteristics of this gait include an absence of hat segment movements, including decreased movements of the arms, and a decrease in normally observed trunk rotations. You should find a link to a video demonstrating Parkinsonian gait in your note-taking Word document. The next gait we're going to look at is ataxic or coordination-impaired gait. This gait is seen following cerebellar lesions that can produce uncoordinated movements. Ataxic gait is associated with patients using a wider stance so as to increase their biomechanical stability and to counteract the increased variability that's seen in both their arm and trunk movements. We also see an increase in variability in their stepping. This variability is evident in gait parameters as more variable step lengths, more variable step widths, and more variations step to step in the degree of toe-inning or toe-outing. The gait of individuals affected by cerebral palsy is characterized by an anterior pelvic tilt, flexion, adduction, and internal rotation of the hip, knee flexion, ankle plantar flexion, and foot inversion. You should find a link to videos of both of these gait patterns being demonstrated in your note-taking Word document. Let's take a look at how impairments that are focal to a specific joint impact gait. At the ankle, there are a number of reasons why you might expect to see increased plantar flexion. This includes heel pain, plantar flexor tightness or spasticity, and plantar flexor contractures. Plantar flexor tightness or spasticity is seen with pes equinus in the gait of individuals affected by cerebral palsy. In pes equinus, the plantar flexor muscles and Achilles tendon are tightened. This limits dorsiflexion of the ankle. Plantar flexion contracture refers to more permanent changes. In individuals affected by cerebral palsy for extended periods of time, we see structural pes equinus that results from insufficient linear growth of the calf muscle compared to the amount of bone growth. This produces a plantar flexion deformity. Here we see some of the characteristics of increased plantar flexion on gait. Increased extension of the ankle will produce increased vertical excursion of the body's center of mass. At initial contact, we may see midfoot or forefoot striking rather than heel striking. In mid-stance, in order to keep the body upright, the increase in plantar flexion is offset by knee hyperextension. At terminal stance, to keep the body upright and to keep the body's center of mass above the base of support, a compensation of a forward trunk lean is often observed. Continuing our look at impairments focal to the ankle, next we have foot drop gait or high steppage gait. This gait is associated with peripheral neuropathy or paralysis of the dorsiflexors. Paralysis of the dorsiflexors is seen with perineal nerve palsy. Again, you should find a link to a video demonstrating a foot drop gait in your note-taking Word document. In a foot drop gait, we unsurprisingly see a foot drop and a associated high step. We also unsurprisingly see no heel strikes. In terms of compensations, we observe increased hip and knee flexion to aid in lifting the swing limb up away from the ground. This elevating or stepping-like motion of the swing limb is combined with a vaulting of the opposite limb. This vaulting further raises up the body and increases clearance. The last ankle impairment we'll look at is ankle arthrodesis. This refers to a surgical immobilization of the ankle. Typically, surgical fusion of the tibio-talar joint is performed with the ankle positioned in a neutral posture. With the ankle fused in a neutral posture, plantar flexion of the ankle is not possible. This means that push-off from behind in the terminal phase of gait is not possible, and that initial contact at the beginning of the gait cycle is going to be biased towards a heel strike, with midfoot striking being biomechanically more challenging. Let's move on to talking about knee impairments. Typically, during the loading response, the knee is slightly flexed. This allows the knee extensors, such as the quadriceps femoris, to eccentrically contract and to absorb the impact of initial contact and to create an anti-gravity extensor torque that holds the body upright. Weakness in the quadriceps femoris can impair the knee's ability to create this anti-gravity extensor torque. Knee hyperextension is seen as a compensation for quadriceps weakness. Hyperextension of the knee, known as genu recurvatum, occurs when the leg excessively straightens at the knee joint, putting stress on the knee structures. Hyperextension effectively locks the leg in an extended position, and in doing so reduces the need for knee extensors to produce the extensor torque that is typically used to keep the leg straight and to maintain an erect posture. Let's look at another knee impairment. A unilateral knee flexion contracture produces a flexed and therefore shortened limb. Compensations for unilateral knee flexion consequently involve adaptations to the shortening of one of the limbs. On the impaired side, the shortening of the limb by knee flexion can be offset by increasing ankle plantar flexion so as to increase the length of the impaired limb. On the unimpaired side, the leg length asymmetry can be compensated for by increasing hip and knee flexion and therefore shortening the limb on the unimpaired side. Now let's move on to talking about the hip. With conditions such as poliomyelitis and Guillain-Barré syndrome, we observe weakness in hip abductors. Hip abductor weakness often produces a Trendelenburg gait, where, for example, a weakened gluteus medius would lead to an excessive downward drop of the contralateral pelvis during the stance phase of gait, as we can see in the figure on the right. In compensated Trendelenburg gait, we see the trunk lurching over onto the weakened side. Shifting the trunk over onto the side of the weakened abductors during the stance phase on the affected side can help maintain a level pelvis throughout the gait cycle. It also reduces the demand placed on the affected side abductors. Weakness in hip extensors can also be seen in patients with poliomyelitis. Hip extensors, such as the gluteus maximus, play an important role in stabilizing the movements of the hat segments, most notably around heel strike. A compensation for hip extensor weakness is an extensor lurch, in which we see a backward trunk lean or trunk hyperextension during the loading response. This reduces the demands on the hip extensors. In this compensated gait pattern, the patient is relying on the passive hip joint stability offered by the Y ligament. The last thing I want to talk to you about today is impairments in limb shortening ability. Impairments in the ability to flex the hip or the knee or to dorsiflex the ankle all affect the ability to shorten the legs during the swing phase. We might see this in the case of weakened hip flexors resulting from L2 to L3 nerve compression, and we might also see it in the case of weakened hip or knee flexors associated with post-stroke hemiplegia. Compensations for a reduced ability to shorten the limb during swing phase include hip hiking during swing phase so as to raise up the limb and increase the ground clearance of the limb, and circumduction gait. In circumduction gait, we see exaggerated hip circumduction that acts to bring the swing leg out, away from the body and around the stance limb. This exaggerated motion brings the limb further out away from the body and increases foot clearance. Okay, that completes our lecture on the biomechanics of gait.